So let me, we're going to do a thought experiment and some cross-trial comparisons, which we're taught not to do. The updated ALEX trial was presented this year at ASCO. I think the PFS updated with more mature data hazard ratio is 0.43.
Yeah, the median is not reached, and we now it's 35 point something.
Yeah,
so it means that it's going to be difficult to displace or to replace or to fight against alectinib at the time being. The hazard ratio for the brain progression is 0.16 and so on and so forth. But like you say, it's about maturity of data. It's about time frame. You have started later, and the data we need some more time to accumulate. I think both drugs might have very good safety profile, very good efficacy, maybe even equivalent at the end when you have a longer follow-up, but they have slightly different toxicities, right? I had this patient under alectinib in the ALEX trial with this muscle pain, which was really limiting, and you will have this problem of dyspnea, which might sometimes prevent some patients from having the favor for this drug. So there will be different drugs. It would be good for the patient that they have the same magnitude of benefit, but still, alectinib has a kind of some meters in advance or some achievements before that makes it kind of still a standard to me.
I think,
but I'm a bit biased here.
Of course, the alectinib data is more mature. So because it's more mature, we understand the toxicities better, we understand the efficacy better. The one thing that the brigatinib data has shown is that we have no new safety concerns with brigatinib. In fact, the early pulmonary events is at much less rate in the frontline setting than you see post-crizotinib. And they are very different in terms of their toxicity profile. So, I think both are potentially reasonable options to use in that setting. And, the real key issue here is how does the maturity of the data with the ALTA-1L affect really what we see as we move forward?
Let's say we do have mature data and the data holds up and it's similar to ALEX, and we look at the crizotinib refractory cross-trial comparisons. That data looks fairly comparable, perhaps favoring brigatinib in terms of its PFS, although again, cross-trial. Let's say it all holds up and it's similar. Does the difference in pill administration make a difference? 1 pill a day versus 8. Is that something that you think, and I don't think there's a right answer here, but would that change potentially what patients would want, deciding between 4 and 4 with the alectinib versus just 1 or 2? I don't know how the brigatinib is dosed. I haven't used it yet. 1 a day with brigatinib, does that make a difference for practitioners?
What will make a difference, Ben, is as we understand the resistance mechanisms for these two drugs, what resistance pathways are activated? Are they different between these two drugs? For instance, we know that the G1202 mutation tends to be a very resistant mutation to treat. If we see a difference in how frequently we see that between one drug versus the other, that might guide how we use. My own view of this whole field now is alectinib clearly has the pole position in Formula 1 parlance. Right? The question was, is there space for anything else? The ALTA-1 trial clearly shows that brigatinib probably belongs in that space. It's a bit too soon because with more follow-up we'll have more information, but clearly this opens the space up for us to have these kind of conversations. It's a good position to have when you have more than one drug and figure out what's the best one for our patient. So I find that the ALTA-1 results are exciting. It does add to the existing landscape, and we will be learning more about this with resistance mechanisms particularly that I'm looking forward to.
And it will be also challenging, particularly for the Asian population, Japanese population, for which with alectinib you have also a specific trial with the G-ALEX. So with strong data of efficiency in the Asian population, ALK positive. So that's why I don't know if we have this type of benefit in the ASEAN population with brigatinib and the same magnitude of benefit, but that might be something that should be also considered for the ASEAN country and ASEAN population.
Absolutely. So the brigatinib trial was a global trial. It recruited patients from all around the world, including Asian patients, and we've not seen any challenges with efficacy or safety in that population. I would suggest that we have similar benefits and no deterioration in toxicity for that Asian population.
We'll have a specific trial presented in the presidential session at the ESMO meeting for Asian population with alectinib. It's called Alesia, which will probably also, it's not about, I agree with you, if the drugs perform the same, we will have to look at practical potential parameters, accessibility and cost will be one, right? The pricing of the drugs. Maybe the pharmacology at the brain level will be another one, translated by PFS at that level. But we might have to look at details to differentiate. So all these data, it's very nice. We have maybe too many options, but all this data will help us choosing over time. And resistance is very important, and how much you can action after these drugs and be successful for your patient will be a very important parameter.
And just another thing, what is the most probably impressive for me with the alectinib is the prevention of the brain mets, again. So it will be something also important to look at for the brigatinib. If we have this type of data and magnitude of benefit on the brain area, not to treat the brain mets, but again to prevent the brain mets, because again, I think this is something.
So in 1L, we've looked at the computer risk analysis as you expect for both intracranial events and extracranial events, and in a similar manner, brigatinib is highly effective at reducing the rate of new CNS metastases developing, and we'll have a much more robust, detailed CNS efficacy data set presented hopefully at ESMO meeting.
So where does, if we think alectinib for now, at World Lung Toronto 2018 is still the preferred first-line drug until we see more mature data. How do we sequence these drugs? Alectinib comes first. It's a similar theme with osimertinib, and what comes next. What comes after alectinib? Is it brigatinib? I don't think we have a lot of data with that, although brigatinib, to my knowledge, does target G1202R. Is it lorlatinib or is it chemo? How do we do this?
It's interesting. Well, what we know is we have this algorithm for preclinical or in vitro kinase activity that helps you maybe choosing for every single mutation. But the G1202R, this one which is more and more encountered, the more you accumulate the TKIs and the more you go to next generation, is a challenging mutation. And brigatinib theoretically in my in vitro model kinase enzymatic activity might work, but very few reports on, I had 2 case reports I think in JTO, but we need really to have more data. But lorlatinib has shown a bit more of data here. And you have a nice waterfall plot telling you that at the brain level, at the systemic level, this might be the next option. And probably lorlatinib is a challenger also in terms of frontline, but has some toxicities, right? So what I would say for lorlatinib is it's a good opportunity for this specific mutation of resistance. So after alectinib, I would tend to try to get a molecular assessment, but sometimes it's difficult. But if you can get it, I would do that. And I would try lorlatinib because we had really very good responses with this 3rd generation TKI in this patient. I would probably not go to the same 2nd generation, but move to lorla.
And don't forget pemetrexed, a wonderful drug in the absence
sure,
of,
absolutely. The chemo
of a
afterwards,
chemo
right?
that can certainly be active in the ALK-Rearranged. David?
Completely agree. I think lorlatinib, one of the issues, and we will wait the phase 3 trial ongoing in comparison to crizotinib, is the tolerability and the toxicity. And I think it will be an issue in first line of treatment with the lorlatinib, particularly if we compare directly to brigatinib and alectinib with so nice tolerability. And I think this is something important. And for the lorlatinib, it will be an issue. And I'm quite confident of the efficiency of lorlatinib beyond progression to alectinib and brigatinib, particularly if you develop this mutation of resistance that have been well demonstrated, and particularly also the potential to be efficient even if the patient progress on the brain area with the lorlatinib after alectinib. And so I'm quite happy to have lorlatinib in 2nd line of treatment for this population, and after perhaps keep chemotherapy beyond, particularly with pemetrexed. And after the last question is, why not to try to make an association of chemotherapy and ALK-TKI? Yeah. We are coming to this association for the EGFR. Yeah. We might also look at perhaps also for this ALK population.
Good point.